Don Navarro, Chairman of KPN Health. Don has provided strategic advisory and management services to the boards of directors and senior executive management teams in multiple industries. Marc, unfortunately, could not make it. So before I open it up to questions, I wanted to share a story. Given that I run MedCity News, sharing stories is what we do. So this story is about the frustration of dealing with the healthcare industry. I had purchased dental insurance from my mom, and she needed to go see a dentist. So I go to said insurer's website to try to find what's in network. Either I'm too old or the website is pretty bad. I couldn't find what I needed to find. So I thought I'll just pick up the phone, call, and try to get them to send me a list of in-network dentists. So I called, gave them my mom's member ID, and I said, can you please send me, within a reasonable radius, some providers who are within network. So the gentleman said, absolutely not a problem at all. What's your zip code? Gave them my zip code, emails me the whole list of providers. Happily take my mom to the dentist's office. 2 or 3 weeks later, I get a bill from the dentist's office saying that the insurer did not cover. And I'm like, why? Why did they not cover? They just sent me the list. You were number 2 on the list. And they said, well, we're out of network. And I'm like, what do you mean out of network? So I call the insurance company, scream at them, and basically say, your customer sales representative sent me the list, and I looked at the list, and I called the dentist. So they said, well, you have to contact the appeals department. So I contacted the appeals department, sent them the email that was sent to me, and then I get a letter on Friday saying that, well, the list that was sent to you was for a different health plan, and you have B health plan. And so if you have B health plan and not A health plan, those dentists are out of network for you. So my one-word description of healthcare system is frustrating. And now, one-word descriptions for each of you, followed with a little story of your own. Brett, you go first.
Sure, well I just know from many stories like that, my word is sick. And part of it's just from having, knowing that how the incentives are typically done in healthcare, which is treating sick people. So I guess people get paid more, the more sick people there are. I know that's starting to change, which is amazing. But it's certainly taking decades and decades to get here. So so I think just making it easy on patients to get healthcare. And it was an interesting conversation that we just heard about mental health care, and I think if people don't have it, they can't really kind of easily have compassion for people that do, and therefore that's been largely out of the conversation in terms of how we as a country deal with those type of patients. So I find that like many things, it's a great challenge and therefore a great opportunity.
Perfect. Tammy, one-word adjective.
Well, since I worked in government for many years, my word has to be bureaucratic. I'm so happy there's another organization as bureaucratic as we are out there. And in my own personal experience with working for the city, and now I do a lot of consulting for different governments to sort of look at procurement in a different way. Local government, we're not counting the feds, we're just looking at local government, spends $700 billion a year across the board, and that's universities, school systems, cities, and counties. And one of the biggest challenges for us is meeting you and bringing the latest, greatest technology, because the way the system has been set up in the past is to put a bid out on the street and then hope people respond. In the past it was low bid, we've moved to best value now so we can have other considerations. But the best and the brightest aren't necessarily coming to government, and they accuse us of being so bureaucratic, and that's part of the reason they don't approach us. But there's money to be made in government. We spend in recessions, we spend in depressions, and we spend in good times. So it is a market.
Don.
My perspective and word is going to come through a business lens. That's my life. Businessman bringing outside business thought, methodologies, experiences to healthcare is what we are about. So my one word is chaos.
I'm glad you're laughing. It was quite depressing to start off with the adjectives that we have. So Donna, I'm going to stay with you. You have, as you've mentioned, you've brought perspectives from other industries. So what is when you first began thinking about, bringing some of your expertise to healthcare, which is the area that you wanted to target on, and what is the particular malady you wanted to solve?
None of that. So when I approached healthcare, when I say it's my business partner and wife, Kim Pachanik. She's in the back of the room. She is president and chief operating officer of our company. I have spent a lifetime going from one troubled industry to another. And so when healthcare, the Affordable Care Act came about, we said a troubled industry. So we turned the turret into this industry. Where is healthcare going? So we did our research, and actually Dr. Dennis Robbins played a big contributing role in helping us to really focus upon what we were trying to achieve. So we said, okay, where is healthcare going? So, and then where we determined best guess and where it might be going, what are the elements required to get there? So we concluded that at the end of the day, whatever year that may happen in, would be a greater collaboration between the patient and the provider. So we said, okay, then we're going to bet our model on that objective. So now what are the key factors? Well, this made sense from other industries that they have data and information. And then you have data, and then you have data. So we said, okay, then what are the elements to get the data in a way that it could really be used and be actionable? So that's where we started. We started acquiring, licensing, obtaining the best talent we could from outside healthcare, not inside healthcare, so that we could then start to put together methodologies and innovations and apply things that we knew worked in other industries and adapt them to healthcare. So that's where we started, and I'm not sure that I'm precisely answering your question, but with the data, then we said now we have to empower, make that data available. And so how do we do that so that the clinician on the one end of a continuum can have the data he or she requires? At the other end of the user continuum, the management who need to understand financial risk, population risk, so that they know how to negotiate reimbursement contracts or how to make choices as to which stage of an ACO they may want to be, 1 through 5, next gen, etc.
So Don mentioned data and how you need to focus on the right data to be able to make the changes in terms of outcomes and so on and so forth. When we spoke ahead of today to prep for this, Tammy, one of the things you mentioned was it's the RFP process sometimes is blind to some of the regulatory changes that are happening, so that data doesn't come to you. How does that affect you when you're trying to buy healthcare products for the city?
And actually, it's anything that's cutting edge or changing. So it could be technology based. It could be even something as simple as a light pole. You go down the street and you see that simple light pole. We don't buy a light pole anymore. Now it's a lighting device, and it also has cameras attached to it, and it's also solar powered, and that's where the power will come through. And so that's all the high-end stuff that we have to sort of get educated on in the middle of this RFP process. But then there's the downside, or sort of the simple side of that. A light post in San Francisco last year fell. 3 stories high light post in the middle of a busy intersection. You would think, what the heck happened? What technology broke? It wasn't technology that broke it. The mere bolts on the bottom of that light post had rusted over time because of everybody walking their dog who peed on that, and every homeless man. So now purchasing has been all high in the clouds, thinking about lighting and cameras, and now I gotta think about urine on the bottom of it, and now there's a special paint that I need to. So procurement in particular, I was buying everything from police helicopters to pencils and papers, so I know a little bit about a lot of stuff, but I never really can get into the depth of anyone. And there's recent surveys done by public procurement, and the one major issue they have is time to do the research. We don't have time to do the research. We have to give a best guess, put that RFP on the street, and kind of hope that we've covered everything. So part of it, and there is a big transition as a result, is we're now partnering with companies. And so that sort of iron curtain wall where we're not allowed to talk to a vendor has come down a little bit. We still have our procurement process and we still have to have transparency, but there's more conversations with the industry. What should we be including? What should we be talking about? What's on the horizon? Because you know your industry way better than we do. So there's more of an evolution of partnerships and putting more open-ended RFPs, RFIs out on the street rather than us defining what's out there. So that's an evolution that's happening.
Brett, you started off in the clean tech, and healthcare is so sick now you want to invest in it. So I'm curious about that transition and what made you decide to put that first dollars into a healthcare startup.
Sure, well, you know, some of you might know from Lululemon that it's a very health-centric company because it has the yoga component, mindfulness component. It's all about people reaching their exercise goals or just, you know, generally their health goals. And we used to have all the staff actually put up their goals in the back of the stores, you know, their health goals and their personal goals and career goals. And just from that, the standpoint of someone actually having their own personal health goals, you know, because I think, you know, even for me, it was kind of unexamined other than maybe my goal of to run a marathon or something. But I actually think that if people can set their own health goals, there's a lot that they can, there's a lot of things that their health can actually, it can actually be a lot better than it would if it wasn't unexamined for themselves. So I know for myself, like my shoulder was hurting from swimming, and I just thought, okay, I'm kind of getting old, and it's going to keep hurting forever. But then, you know, I set a goal that you know, my shoulder would be pain-free in 6 months, and it had this interesting effect where I was all of a sudden, you know, looking on YouTube, going to the PT. I found some great stuff, and actually, I am pain-free now. So I think part of my interest in healthcare is the fact that I love the human behavior part, the psychology, and the complete opportunity in it, because there's so much that needs to be done. And I think it's all going to really start with the patient. You know, it's the patient's got to have the goal of being healthy. And once that happens, I think everything changes. And I don't think it's a good partnership if the patient really doesn't have the goal and the health system's trying to help them, but they don't really want to get better. Once the stars are aligned and the patient wants to get better, I think the healthcare system will start to get more organized, you know, less chaotic, and more focused on it. So just through that interest, anytime I happened to be getting pitched a healthcare deal, I kind of lean in and just see what it was about, and I found one recently that I liked and invested in.
So I'm going to push back a little bit on that setting a goal for yourself. Because in many cases, there are social determinants of health that sort of have a pretty giant impact on what your health outcomes are going to be. So when you look at maybe a 45-year-old mother of 2 with an opioid addiction, she doesn't have time to set goals for herself. So in that sort of situation, what role can healthcare play to make her journey a little bit easier?
Well, maybe the start would be to have a culture of setting those goals. So the start would be, you know, what do you want your life to look like in a year, 2 years, or 5 years? Do you still want to be addicted, you know, to opioids? That'd be a good kind of question to start with. And then getting in a culture where people realize that works, and getting people, and because I think it's interesting if that woman came out and said, my goal is to be, you know, free of this addiction within X amount of time, I think, you know, resources start lining up. It's just the people that, and then they actually make progress on it. It's just the people that have the thing and someone else tries to help them, even though they don't really have a stated goal to get better. So I think it's kind of turning the tables around a bit and just making sure the person can get in that culture as a first step. Like the first thing is, how do we have them set some health goals?
I think what you're talking about also is patient engagement in how we talk about almost engagement, because no one really thinks of us, even if I am taking like 4 or 5 medications a day for several comorbidities, I don't think of myself as a patient, I think of myself as a human being, as a person. So maybe, to use Dennis's word, we had developed a healthcare system that's more person-centric as opposed to patient-centric, although it could be semantics in a certain way. So Tammy, wanted to ask you a little bit about that. As a purchasing manager in the past for City of San Diego, you were also representing some really people that are disadvantaged and not able to get some of the resources. How did that sort of perspective color the sort of decisions you made in terms of purchasing?
Well, unfortunately in politics it gets very reactive. Things can happen, things can be passed, and then suddenly we're in the emergency mode. In fact, the purchasing agent changes hats during an emergency. So I was the purchasing agent during the Witch Creek fires, the worst fires ever in San Diego. So I immediately become emergency logistics chief and have to handle the emergency working with police and fire. But in a city government, and that's where I worked, a lot of times, at least the conversations I've heard earlier today, it's more, you're talking more about the hospital or the clinician, or they're already at the doctor's office. But a lot of times those people are actually touched by a municipal employee first. So the police department has showed up to a domestic violence situation, or the firefighter is there to perform resuscitation. These are city employees. Or a code compliance officer is out there and for a hoarding issue, but then finds out there's mental issues that they're having to be addressed. So I find there's a huge disconnect, because we're the police, we're the fire, and we're code compliance, and you're health and human services over there. And so if anything, part of the new philosophy should be combining those forces, because those people aren't just walking into a hospital, they were found by a cop, or they were found by a firefighter for that portion of it. But we do serve the most disenfranchised folks there are, the homeless, the school systems, the kids who can't afford school lunches. Those are provided by the purchasing agent, buys those lunches for those kids. So there's a phenomenon where a lot of you are talking and working with people who can have a car and get to your office and get the help, but we're dealing a lot of times with other issues of people who can't get to those services, and so it results in crime, it results in code enforcement issues, other kind of those stats that the government now has to deal with, that if it was taken care of more on a health issue, we wouldn't be having as many problems as those to deal with. So I believe there's more, we should be tightening that gap between the two of us to start working better together.
And that's happening industry-wide. You see collaborations between pharma companies and digital health companies, and payers and digital health, and medtech and connected health. So I think that's happening slowly. Dawn, you talk about you cannot manage what you cannot measure. And so now that you're working with outpatient clinics that have a defined set of population that come and go, what are the measures that you're asking them to focus on? Can you talk a little bit about some specifics?
Certainly, but before I go there, would you allow me to just make one comment?
Absolutely, sure.
Prior discussion.
We interrupt and interject, so feel free.
No, I would do that. I am not qualified to speak on what you two just spoke about, the social aspect of it, but I feel as if maybe if I share my story just quickly, it may share with you, maybe you can relate a little bit to another dimension of what you talked about. My father came here in 1939 as an illegal alien from Mexico, got his papers in 1944. I was one of 9 children. He was a professional boxer and an auto mechanic. I had 5 brothers, and we had a boxing ring in the backyard. Dad said, it's tough out there, you've got to learn to be tough. Forbade the speaking of Spanish in our home, saying he wanted his children to learn the money language, and that we would get an education, we would learn to work. So I lived the poverty, I lived being in the clinics, and what I always knew was hard work and education. That was the only social determinant that I could abide by and live. And so I chose the business route because of that experience and having lived in the clinics in poverty and having seen two of my brothers not make it out of the poverty, one murdered, another died shot. So, you know, I lived that life and I said, okay, God has blessed me with an ability to be in the business realm. I can make money, but that's not for self-aggrandizement. What can I do with that money to go back and help? And so, as a result, my wife and I have helped many young people, and of course it's extended beyond now just the Hispanic community to the black, the women, and all. But that's, I think that is, you know, a form of leadership that I think is important. It contributes holistically to what we're trying to accomplish with health-wise, because it's just important that people understand, you know, where they come from, where they're going, and the country we live in. Now, manage what you can't measure. Outside healthcare. Healthcare is really interesting to me because it's a term of acronyms, and I come from a world of terms of art. Things mean the same thing, and people can make decisions based on documentations. And healthcare contracts have got more definitions than I've ever seen because they have to be sure that this acronym meant that, not this. And so when you get into, I smile a little bit when I hear of all the MIPS macros, conversion from fee-for-service to pay-for-performance. We've been doing that for years. I chaired compensation committees in public companies in the New York Stock Exchange for a total of 15 years where we dealt with performance-based compensation. We set, you know, 3, 4 objective criteria, 2 or 3 subjective criteria upon which you would measure performance. So when we looked at that from a business realm, bringing it into healthcare, we said, well, okay, data. I started this conversation, data. So now we have to have, you know, applications that allow the performance to be measured more precisely. If you're going to have some type of MIPS, well then you've got to know, you can't wait until the end of the reporting period to know how you did. So you've got to be able to take data dynamically and measure the performance against the data. Well, we did that. So we had the data in our platform. We developed the quality performance module because we knew that would be needed somewhere along the lines to manage performance. And manage performance reaches not only to the financial aspects, but it reaches also to other, you know, subjective or other criteria that have to be measured to gauge how you're performing, but not just financial. So that is what I mean by you can't manage what you can't measure. Other industries do that every day. Healthcare needs to learn to do that more and better.
So you're essentially talking about a huge culture change, and I just see that in how I deal with the level of service I get in the consumer world as opposed to the level of service I get in the healthcare world. I think patients also need to push back. There is a deference that we have towards doctors, towards whoever we think are in a position of power over our well-being, where we don't push back. And I've in several occasions, you know, if I got too upset, my brother was actually a stage 4 cancer patient, and he recently passed away. And anytime my mom would detect a hint of frustration in my voice, and when I'm trying to talk to the doctors, she would say, "Oh my God, they're his doctors, please don't do this." But she has no qualms if I'm screaming at some rep at some other industry. Totally legitimate reasons for both.
Well, it's the same in government.
Right.
I mean, if you have a politician or a mayor, I mean, even when you address a mayor and council, you're supposed to address them by honorable mayor and honorable city council, whether you feel that in your heart or not. You still have to say that.
Right.
And often they are making decisions or passing policy that affects all of us, including we city workers who now have to somehow turn that social goal or policy into something workable. And in a very recent case that just happened, and my peers who now run purchasing at both the county and the city of San Diego had to deal with one of the biggest hepatitis A outbreaks in the nation in recent history since the vaccine was actually created. And what happened is it came out of politics. And it just so happened the mayor decided that we were going to have a baseball game called the All-Stars Baseball Game at Petco Park. Well, he wanted the city to look good for the media and all the tourists coming in. So rather, you can't move the homeless out, they are human beings, but what you can do is take away all the public restrooms and all the porta potty facilities, which was done. So they were removed from downtown area, and I don't work there, so I can speak freely because I'm not gonna get in trouble. And at the same time, this was back last year, in November, if you'll remember, those of us who live in California, we also passed a referendum that there shall no longer be plastic bags, and now you have to purchase plastic bags. Well, without getting too graphic, I guess a plastic bag is plan B if you can't find a porta potty. So we took away porta potties, we took away plastic bags. Well, the homeless ended up going everywhere, including the canyons and downtown, which created a hepatitis A outbreak. I know, that's what I say. Well, and it was all due to tourism and politics and all of that. Well, who had to step in but poor County of San Diego, who had nothing to do with any of this, because remember, that's a state and the city, and now they had to buy millions of dollars worth of vaccines. Not only purchase the vaccines, we're dealing with a homeless, transient population. They had to hire special nurses who would be willing to administer the shots. Not only that, they had to hire guards and security services to go with the nurses because they would transverse in the canyons. They had to hire speech and language experts because not everyone spoke English. I mean, they have spent millions. That's just for the people in the vaccines. They had to go back downtown, install twice as many porta potties across the city. They had to bleach all of the sidewalks on a daily basis. And they had to deal with environmental concerns because remember, they've got the painted dolphin on the sidewalk, please don't put anything into the storm drain. And yet they're blowing bleach down into the storm drain at the same time. So there was environmental mitigation they had to do. All for a baseball game. And that's what happens. You thought purchasing was boring. Government purchasing is so exciting.
Don't go putting words in my mouth. So Brett, again, drilling a little bit deeper in the culture change. What would you like to see as an investor in healthcare that's slowly thinking that there are exciting things happening? What would you like to see within customers of your healthcare startups? What kind of culture change do you want to see to make their products, more easily adopted? Because one of the things that we continue to hear when we report is death by 1,000 pilots, where startups go from pilot to pilot to pilot to pilot, all of them free, and they never get adopted. So, as an investor, what would you like to see from the customers of your potential customers, I should say, of your startup?
Well, I think it's a big issue, and I was hearing some conversations earlier today about getting on. The Kaiser had 525 pilots going on at one time, I think, in pretty recent history, and how John Mattis, who works for Kaiser, was like, we can't have this many. Of course, a ton of them are going to fail. It's just too many, and so then the question is, how do we get more of them onto one platform, or how do you just make it easier for a big organization like Kaiser to just deal with these? And I think they love to be on the cutting edge, and I'm sure a lot of other health networks do. So how are we going to help these particular startups get from A to B to C to D, and it's not always efficient. One that we have has a pilot going on in Israel, because there was a relationship there, which is kind of ridiculous because, as a startup, it's a long way away. There's travel. There's all kinds of issues where maybe we should be dealing in our backyards, like was mentioned earlier, and last year the city we're in. But if we're not getting the kind of traction we need there, we have to go outside and spend extra money. So I think it's a very complex issue, but having people kind of realizing the end goal and having a champion somewhere in some system to take you on as a startup, maybe government can play a big role because they're they can look at the long-term costs of having, say, diabetics. In our case, with Mellitus Health, it helps doctors properly dose insulin with their patients. So when they're properly dosed, they have there's great benefit in long-term healthcare with these patients and even immediate healthcare costs. So how does government help us? Because if they help us, we can help them. But then again, without having to deal with thousands of little companies.
And there is a trend, there is a smart cities initiative going across the country. In fact, City of San Diego is now a smart city, City of San Jose is a smart city. So there's several, and it initially started in the technology, looking at, you know, the things we buy computer-wise, but now it's spreading into other areas, how they're all co-related. And so health is one of the issues. I just attended one of their conferences, and they're starting to integrate some of the health issues, which is interesting as part of the smart cities, because they will save. You'll save policing, you'll save firefighting, you'll save, there's in cost to investing in health, which isn't a traditional city expense. For counties it might be because they handle health and human services, but they're starting to look at it, well, maybe we should spend some money there because it helps us on the tail end with law enforcement and some of our other expenses.
So Tammy, I'll stay with you. Can you talk a little bit about the company you're with now, the National Cooperative Procurement Partners, and how startups can sort of work with you?
Sure. So the idea behind government purchasing, or at least the traditional way, is that we put a bid or RFP out in the street, and then companies respond, and we go through an evaluation period and we award. And typically a government contract is awarded for anywhere from 3 to 5 years. So yay, if you got the contract, you've got a customer for the next 3 to 5 years. Typically we will renew over time quite easily. But what's been happening is a phenomenon across the country called cooperative purchasing. And what it means is either a government or an organization using public purchasing procedures will go out and do that solicitation and set up the contract. And now other governments and nonprofits can piggyback and use that contract. It's called cooperative purchasing. A new association has been started, and they've hired me as the executive director. But one of the complaints, not only can purchasing doesn't have time to research, they don't have time to put out that many bids anymore. It's just too onerous. And it's sort of mundane. Why do you go out for a bid for office supplies? It's been done 100 times. Just piggyback off somebody else's contract, be done with that. Let me go use my brain on strategic planning and stuff that like cutting edge technology. So right now studies have been done in an individual organization across the country, a government agency, is using anywhere from 11 to 19%. That's the average of their spend going to co-ops. So if they have 100 contracts, 11 to 19%, they're not going out to bid anymore. They're going on one of these co-ops. So what does that mean to you? If one of those cooperatives, or you see a government agency putting out a contract that's going to be used in a cooperative manner, that's where you want to put your time and energy to responding. Because if you get that contract, you not only win it there, you could win it across agencies across the country. And so it's a huge benefit for companies as well, not just governments.
And have you been able to, I don't know how new this group is, so maybe...
The association is new. The idea of cooperative contracts has been around for 15, 20 years. When I mentioned that local governments spend about $700 billion a year, co-ops now make up about collectively make up about 25 billion of that 700. And it's growing over time. So there's a huge amount of business going through cooperative contracts now.
So one of the problems that I've heard in dealing with government is the long lead times and the long...
No, I've never heard that. Purchasing's too slow. I've heard it from everybody. I thought it was too slow. In fact, when I became purchasing agent, I thought, first thing I'm going to fix, these timelines. We've got to go faster. It really does take sometimes 4 to 6 months to put a bid out and get the responses, do the evaluation. It's just the nature of the process we are forced to use. It's not our choice. So yes, it is a long process, but once you've gone through it and once you've gotten the contract, you are good to go for the next 3 to 5 years. And if they have that piggyback clause, that means other entities can use your contract. So you can leverage it when you're speaking to other governments saying, hey, City of Tucson just awarded us this contract. It's got a piggyback clause. Most purchasing agents already know what that is. And so you've interested them. Because now they're thinking, I don't have to go out to bid to get your services. I can just use that contract and go get it. So it's a huge benefit.
So Don, I'll talk to you a little bit about something that I think the healthcare industry tries to hide behind, and that is regulatory processes. And the fact that they say is that, other industries don't have to take into consideration a regulatory about the fact that you're dealing with human life here. And so it's fair that we take a slow, measured approach. Do you agree with that, or do you think it's nonsense?
Doesn't matter what I think. Like it is what it is. Oh, I'm sorry. It doesn't matter what I think because it is what it is. And when you build from a business metric, when you look at any situation that involves business, you take in those factors and you start to model and anticipate how you're going to deal with those factors in any business metric. So with regulatory, yes, so you can't change that. So you better build in a core competency or competencies that know how to deal with that and anticipate. And then it gets back to risk. When you start to look, and Brett would know this better than I, but when you start to put capital to work, and that's human and tangible monetary capital, it's not just money. When you start to deploy, you have to think in terms of risk. And so that risk is very important when you're working with an ACO. We focus on the outpatient sides, and we're specialists in the ACO world, and that's particularly strategically germane, because hospitals today, or those networks, are all messing around with, teasing, considering, do I need to get into the outpatient world, and if so, what's the best way to do it? Well, this is beyond regulatory somewhat, but one of the big drivers that's different today is when President Trump was elected, the political rhetoric was the act would be repealed. Well, that did not happen. And so because it did not happen, now the ACO survives. And the ACO survives, while it may change, that is enough for business people to say, if it's not going to be repealed, it may be modified, but we can live with the modification as long as we understand the risk profile. See, so that, I'm not sure I'm answering your question, but that is something I think is very important. I don't know if now's the time, but I do think it's important to the crowd that at some point I'd like to talk a little bit about something I've never heard anybody talk about in healthcare, and that's banking. Because banking is going to become very important to the business side of anybody or any entity who is in business. So I can come back to that if it doesn't fit, but...
Go ahead, since you started, we don't want to leave the audience guessing.
I just thought we'd tease them a little bit. Well, banking, I am going to tease just a moment and just ask a somewhat rhetorical question. Is healthcare today a business or is it a profession? And that will confuse some people. The truth today, it is both. And so in any business, there has to be the monetary side, the financial. So when the entity that whether it be an ACO practice, whatever it is, a hospital, there will be some banking relationships. And bankers today, largely as a result of the Dodd-Frank Act, they're operating under tight restrictions. And so the way they will measure and assess a loan is the ability to repay, and then certain well-established covenant ratios that have to be met and maintained. So we were meeting with bankers recently, and I asked the question, and I thought we were going to have to call an ambulance. Because I asked the high-end bankers, and I said, tell me how you value collateral. How do you assess it? Is it the ability to repay? Is it the ground, the dirt, the building? Is it all cross-collateralized, cross-defaulted, cross-pledged under the Uniform Commercial Code? How do you see that? Well, always the ability to repay. And I said, well, do you weight or put formulae together like we would do in an asset-based loan? Just say the receivables are worth so much, and advance rate against that dollar? Well, somewhat. I said, well, you may be in trouble. I said, today, there's no way anybody can project a revenue stream based upon some kind of predictive reimbursement. I said, today, the performance criteria has been established by CMS, and if you don't meet that performance, you may not get, depending on whether you're at risk or not, or you just fee for service, you may not get the number you thought. And that's the good news. Bad news is, depending on whether you're next gen or not, you may be penalized. So you may have to give some money back. So, Mr. Banker, how does that sound to you? I said, if you've got a big portfolio today, you know, some of your portfolio is probably not good, and you're going to call that bad bank, and that's what it's called in the credit industry. And others are existing ones that you have to monitor so you can meet your regulatory requirements. And oh, by the way, they may want a little bit more money too. And then you've got others who are going to come to you for loans, and you're going to assess your ratios. So what the hell did you just do with your metric? It's out the window. You don't have it. I said, oh my God. I said, so there are ways to do that, but it has to marry up with the data that is being pulled together today, the data stores that are being put together that house the client or the business's data. And then you can put tools on top of that, algorithmic tools to make sure the data is accurate. And then you can take that data and then you can start to assess the quality of your collateral, your ability to repay, et cetera, et cetera. So all of that's coming, and I just want to put it out there because anybody in this room is in the business and that thinks that will not affect them at some point, even if you're on the clinical side, you're wrong, because it's coming.
Now that you scared everyone, I think what maybe to drill down a little bit on regarding what you said in terms of the hospitals or health systems' ability to pay back loans, I think that's why they're focusing deeply on population management and in terms of having a defined population and looking at how we keep them well so they are not coming to the ER and getting care in the most expensive way. And talking about banking, I wanted your reactions about JP Morgan, Amazon, and Berkshire Hathaway getting together to try to solve healthcare, and basically probably showing a middle finger to all the payers and saying, we're going to solve healthcare, we don't need you, healthcare industry. Brett, why don't you take a shot?
Wow, well I think, you know, on one hand I look at those three entities as being just like more of a top-down approach to healthcare, which scares me a bit. That it's, you know, going to be kind of all about efficiency, which is okay, but at the end of the day, you know, we do have people, and I don't, you know, kind of going back to that thing, you know, how do we partner? How does the patient partner with the physician or the care organization? And I'm not sure. I think that approach is great from the standpoint of how Amazon, you know, approaches doing things super efficiently in their network. And maybe JP Morgan will be adding the, you know, expertise on the financial side. And I don't know about Berkshire Hathaway, they know how to make money. So maybe with the combination of three, there'll be something there. But I also think that there may be things missing too, because it's not like even, you know, when Bill Gates went to Africa or the Clinton Foundation, there was a lot of like academic hope that they would make big differences in certain populations they didn't really know much about, and a lot of that failed, or there's a lot of wasted money. So I'm just kind of wondering, will there be a lot of wasted money in this as well? But
well, they have the money to burn, right?
Yeah, that's true. But you know, maybe the healthcare business needs a kick in the butt. So this could happen.
Well, Amazon's doing something similar in the government space. In fact, they're saying you don't need a purchasing department anymore. You just go on Amazon and buy it. And most of our users are like you. They've been on Amazon. I myself shop on Amazon. But is that the best way to buy government stuff? What about warranties? What about returns? What about standardization? All, you know. And then the sneaky side of me, and this is me just being the paranoid government person I am. So say we get all government spend on Amazon, and it's really a user experience. That's what you're going for, the quick user experience. But say all governments, over time, they collect the data. All governments buy paper and toner on Tuesdays. So every Tuesday, paper and toner can go up by 10 cents because that's when governments buy, because they own the data. And so there's the cynical side of me that I'm not so sure I would trust one company with all of the government buying. there's part of my role as purchasing agent that I still have to bring the best value for my residents and taxpayers. So there's a concern for me too of one big company just saying we can do all of this and not involving the end users or end people who are going to be touched by it.
Yeah, that might also affect local businesses that you may want to support.
Yeah, and our MBEs, our WBEs, our local mom and pop shops, we've just wiped them out of the equation because for them to get a contract with Amazon, they have to give up a lot of profit, a lot of leverage, a whole lot of things. So we've wiped out a whole industry within our local economy as well. So there is that.
Done.
People generate all of your revenue in business and all of your expenses. So no matter how you cut it, it's still about people. And you just can never lose that perspective. One of my concerns today, and I'll touch on the subject here in a moment, but one of my concerns today is, you know, through my lifetime, I've had at least 3, I can name, mentors, probably closer to 6. Along the way, have helped me, took me under their wing and showed me. And I just think that's so valuable, and that gets back into people. Well, I have a young man I was working with, mentoring somewhat, and I said, 27-year-old, master's degree, smart. And I said recently, I said, your generation is missing the mentoring. The people connect. Google is your mentor. And that's a lot of what we're talking about here. When technology gets to a point, and it is a different world today, you know, no doubt. When technology gets to the point that we lose the people dynamic, then we're in trouble. So I just come back and say we have to stay connected to people, no matter how great the technology. And Brett may not agree with me on this, or he may smile at me, or worse. But you know, when I hear of the big banks and the Berkshires and all, I think big fees, transaction, and that's what I fought against my whole life, is by staying in the merchant banking side of business, is staying away from the large Wall Street transaction types, because in my other career, I've spent a lifetime working in troubled industries. I have participated in the confirmation of over 50 Chapter 11 bankruptcy plans in my career, and at least that many non-judicially out of court. And it was always the same thing. You had to take a tangible or an intangible asset, redeploy it for greater value, and use the proceeds therefrom to end up with a plan which was nothing but a contract with antecedent interest holders under the absolute right of rules of distribution. So when I come back to business, to me it all gets back to people, and all of this will survive if people are real about what they're dealing with.
So with that, I wanted to open it to questions from the audience. Go ahead.
I'm Arthur Cowler with Psychanalytics, and one of the things that's interesting to me about something that Brett said is it reminds me of the old saying, which is how many light bulb jokes, how many psychiatrists think they change a light bulb? And the answer is depends. First, the light bulb has to want to be changed. And so what I'm wondering is, in terms of Tammy's comments about procurement, one of the issues is you can be sort of lighter in terms of procurement, but you still have to think about what the criteria are for selecting the right people, the right bidder. And it used to be, the high bidder, the low bidder, and the low bidder was the one who forgot wasn't sure what they left out of the bid, and they're trying to make it up in change orders. So part of the issue is, how do you make sure that you get the best bid? How do you have clear evaluation criteria for what bidding you do, and use that in a way that doesn't slow down the process?
And can I add on to what you're saying?
Isn't that true?
No, well, if that gets worked into the cooperative side too, when there's because it would be easier if a municipality knew other municipalities' experience with that.
Sure. So to answer your direct question, typically we don't try to do bids. unless it's so well defined. I mean, so for instance, fuel, or that might be a well-defined commodity that I can lock it down and I can get ratios and all of that. So I might do an auction or a bid on fuel. But if I was going for behavioral services, I'm doing an RFP. And an RFP is broken up into components. Cost is only a small component. In fact, it might be 25%, 20%. The rest is qualifications, references, your proposal. We have a problem. How do you propose to solve the problem? And now we're going to read your proposal, which is your writing and your solution. And then we try to compare that. Is it apples to apples? Not all the time. That's the difficult part in the evaluation part. Sometimes we've gone to multiple awards, so we won't just award to one. We may say, you know what, we need to award to 2 or 3, either because of the amount of work that needs to be done, or we're kind of hedging our bets. We want to make sure we're successful, because I don't want to go do this again in 2 more months and have this fail. So we may do multiple bids as well. And so for you on the cooperative end, sort of for other governments, another reason why they would piggyback, it's already been proven. The contract has been out there for 6 months to a year. I can pick up the phone and call my cohorts, other governments, and say, how's this working for you? Have they been good in responsiveness? How's the customer service? Can I see your data from this contract? And we as procurement people share that. It's all transparent and open information anyway. So that is actually a huge benefit of going with a cooperative. Somebody's already test drove it for me, and it's ready to go. So that's, hopefully I answered both your questions.
Go ahead.
Thank you. This is for Mr. Navarro. As a former banker, our bank decided to get into health care right as the Affordable Care Act was passed, maybe a year before. So we gathered all the financials of all these different hospitals, doctors' offices, etc. And then their numbers within a year were so upside down that we could not bank them. And then they ended up in mergers for survival. And I get goosebumps, and I have 100% agreement with your scenario now, for sure.
Well, thank you.
At the back.
Yeah, I have a question about procurement and the opioid crisis, if we can put those two together for a second. If you think about, the criminal court system, and you think about Narcan, you think about what's being dispensed there to save lives, and then you think about the methadone clinics, and you think about buprenorphine and MAT and so on, where does social policy come in terms of where that spend is going? I don't quite understand that, where the priorities are.
The priority's in enforcement right now, unfortunately. It is not on the front end. It's moving, but from what I've seen, it's been more on the enforcement, more jails, longer sentences, and there are a few salient voices out there that are trying to tie, and I'm sorry I cut you off, but this is something that aggravates me about that.
Yeah, well, it is aggravating, see, and there's another level of aggravation, and that is we have a $36 billion private equity-backed addiction treatment industry right now in the United States.
Yeah.
That's where it is. And so it's primarily inpatient, and we are not doing anything on the outpatient side for these people that have a chronic condition, a chronic disease on the OBOT side. And so I think the public sector is great. We've got the federally qualified clinics, we've got methadone centers here and there, but there's no intersection going on with the commercial side of this. So I know I'm getting off tune here, but what are we doing about the outpatient side of this treatment and getting these people off the streets and into treatment, and why isn't the commercial sector stepping in to address this, and particularly the employers?
Yeah. You're right. In fact, there was an incident that just happened in little old Omaha, Nebraska. Their procurement department went out for breathing apparatus for the fire department, which is a no-brainer. It's fire safety, it's going to get passed. If you're buying anything for fire, it's going to be passed. So they go through this process, and it's only about $10,000, $15,000. It's not even a huge purchase. So it's a Tuesday. That's the day of the council meeting. The Sunday night before, 60 Minutes did a huge expose on the opiate crisis. And one of the companies that they mentioned was the very company that the procurement department was buying these respirators from. The city council stopped the award and said, no, we will not give money to that company. Even though we know we're not buying opiates or any kind of drugs, we refuse to give that company the $10,000. So that's kind of a political offshoot of there's it's not helping the health crisis that you just described, but there is a backlash happening at the government end on awarding contracts to these companies for other things outside of the opiates. So that at least is happening.
More questions? So I had a quick question. All of you talked about people and how important it is to be person-centric and not lose track of that. Well, how do you look at artificial intelligence? We're sitting here in the middle of Silicon Valley where there are multiple companies developing driverless cars. There's AI being introduced in radiology areas. How do you look at it? Good thing, bad thing? Bit of both?
Well, you know, I was thinking about that the other day, and although it might be scary, I think we're probably going to get to the point where everyone's data is going to go into one repository in a way, and it can be somewhat predictive of what might be, you know, what health problems you might have, or how you can be proactive in you know, navigating your health. But I think it's scary too, because who knows who's going to get a hold of that, right? But I think AI could, and probably easily in the next 5 years, or yeah, probably 5 years, look at your genomics, your background, your medical history, you know, what you eat, how you exercise, your stress levels, and it could develop a very highly predictive engine. So you'd get pinged and, you know, like, go see your doctor within 2 weeks, and it'd be because now it's pretty manual, right? I go, you know, kind of go in when I get sick type thing. So I think that's interesting, but I don't know about privacy.
Tammy.
This is a personal story. I don't think you can ever take the human touch away. My daughter's a nurse, and my husband passed away 2 years ago from cancer. And during his 4-year battle with cancer, we dealt with all kind of medical, both on the holistic side, Eastern medicine, Western medicine, we did the gamut. His last week in the hospital, he had an amazing young nurse. This young man was amazing. And what he did for my husband during that week, he gave him shots, he changed his bedding. But that young man really made an impression on our family. Sorry. And it was the week he was going to propose to his girlfriend, and he was so excited. And he had my husband coach him through what he needed to say and what he needed to pick for the picnic basket. And I even went and got him a really expensive bottle of wine so he could include it, because I knew he didn't have the money for it. And the next day, my husband was so sick he could barely lift his head, and that young man came in and said, "She said yes." For an awful week in our lives. That young nurse made such a difference, and no AI machine can ever do that. So you can't take the human element out of it.
I favor artificial intelligence advancement. In my life experience, if you're standing still, you're going backwards. So I just absolutely encourage that. Now, that has to go hand in hand with the people side. As we live life, you know, people behavior is not going to change. That we know innately who we are and how we're going to react. So that doesn't change. Artificial intelligence may help change a lot of things, but we still will always need to focus on the people dynamics of how the artificial intelligence is developed and administered.
Well, with that, I'm going to close. Thank you so much to the panel. I thought we had a great